The next speaker I'd like to introduce is Dr. Gary Rodin. Um, he's a professor of medicine at the University of Toronto and director for the Global Institute of Psychosocial, Palliative, and End-of-Life Care. So he actually has a lot of experience with nephrology, actually. But I am really honored to have him to talk to us today about the topic of medical care and human connection, lessons from the pandemic. Gary?
Thanks very much, York. Very glad to be here with all of you. I think I was actually invited here because York and I have been meeting in the parking lot, and this gives us, instead of in the hospital, this gives us an opportunity to talk outside the parking lot. And it's also kind of coming full circle for me. I did actually begin my career. I trained in medicine and then in psychiatry, but I began my research and clinical career consulting to the renal population. And my initial research was in the psychological dimensions of end-stage renal disease. So this does feel, sitting in a room with people from nephrology feels like coming full circle. And of course, we all are in these silos of a specific type of kidney disease or nephrology, but actually for both healthcare providers and for patients, there's so much more commonality about the experience of health and disease and burden of disease. There are many, and so I'll try to talk about some of those kind of things that we've learned more generally. And there's many narratives. I think Errol was getting at that. There's many narratives. There's many stories that we've seen in the pandemic. People who are children and young adults have had a particular kind of experience. The elderly. I've worked for many years now in the field of cancer, and it's been quite tragic to see people in the last year or two of their life have their lives limited in this way. All the things they might have hoped to do, they can't say, well, hopefully in a year or two we'll do those things. And we've all seen our lives narrowed. That so many of the things that we found interesting and engaging have been narrowed, which is why I think it's so nice to come together as we are today. And we had this. I used to be a swimmer, and I am again, but I started running, and I was aware I would like to run in public spaces, actually, because just for the wish for human connection. But we all had this fear. When you saw people at a certain time, your reaction would actually be avoidance, which is sort of, ordinarily we think that's a psychiatric or psychological disturbance if you react to human contact with a wish to withdraw. But what I'd like to talk about is what we might have learned from the pandemic, and I'll focus a lot on the medical setting. Lessons is that word is kind of interesting, because a lesson can refer to what is delivered, but it can also refer to what is received, what we take from, and it might be different. You all might have some different thoughts about that. One of the things and I'd like to talk about, I think what has been revealed, what has been hiding in plain sight, but has been revealed by the pandemic. And I'll start by saying one of the things is that medicine in most parts of the world is taught as the study of disease in individuals. And this is really a very limited perspective, that both physical and mental health has a lot to do with the context of individuals in families, in healthcare systems, in society, in communities. And it took a pandemic, I think, with all of its public health perspectives, to remind us that we're actually part of a system, and that health requires thinking about it in a systemic way, not only in terms of individual health. I don't know if I can, do I have to do something? This doesn't seem to, am I doing something wrong? Can you? So this is the words of Winston Churchill, never let a good crisis go to waste. So the pandemic has limited us in so many ways and created so many problems. Gabriel certainly talked about the individual trauma, the problem of burnout and people leaving the profession, but it also opens our eyes to many things and creates an opportunity for change. And I think one of the things York asked me to deal with a little bit was think about strategies, what we can do. And so what opportunities does this provide us? And I'll talk a little bit about these in general and a little bit about what we're doing in cancer. And I'd like you to think about how this might apply more broadly. Cancer is just a model, actually. The problems of cancer is not even one disease. There's many kinds of cancer, and the problems of people with cancer and of healthcare providers are actually not much different than the problems of patients with renal disease and their healthcare providers. So some of these lessons, this is a Norman Rockwell painting of the law student, but some of these lessons are, I think, lessons that we could have known a generation or two ago, and some wise people did know them a generation or two. And what has happened to medicine, actually, you can tell me whether you think this is nostalgic or real. I would say that something has been gained and something has been lost in the last half century in medicine. That is, medicine has become technologized and specialized, that doctors have lost contact with individual patients. Doctors no longer attend to pain and symptom control in the same way, to the psychological. Just York was telling me a story about a fellow who didn't know how to deal with an upset patient. That hadn't been part of what his training had been. And yet we know that doctor-patient relationships, doctor-doctor and doctor-healthcare provider relationships are an essential part of healthcare. This is what's been lost, I think, to some extent in modern medicine. In fact, the whole birth of palliative care, which began, Cicely Saunders opened St. Christopher's Hospice in 1967, the whole birth of palliative care came because doctors and healthcare institutions were not attending to people with advanced disease. There's a huge study, actually it was called the Support Study in the late 90s in the United States. They looked at about thousands of patients in 5 high-quality American institutions. They found that these patients had terrible quality of life near the end of life. They had poor pain control. They were ending up in ICUs. There was a lack of attention to individuals. So I think this has been laid bare in the pandemic. But the lessons we've learned, I guess, depend on the lens that we look at, that we use to look at these things through. So some people, this is a recent paper, article in the New England Journal. Some people have said this really draws attention to what we need to do to build a national public health system in the United States. There really isn't a public health system in the United States. And, we do have a public health care system in Canada, or at least we have funding for healthcare, but I think the pandemic revealed that we don't really have a system of public health. We don't really have a national system or even a provincial system of health. They said they've identified some of the things that need to be, that have been identified as gaps in leadership, coordination, communications, testing, and attention to critical issues in equity. And when we talk about health, including mental health, we know that the pandemic did not affect people equally. Those who were affected tended to be from the lower socioeconomic classes because they went on public transportation and they worked in places where they were more exposed and they lived in places where they were more exposed. They had poor access to health care. Now, inequity didn't begin with COVID, but it certainly highlighted the problem of inequity in healthcare, including in Canada, where we like to think that healthcare is equal because it's publicly funded, but there's a great deal of inequity also in Canada. And what about burnout? This is a very difficult problem. We know that the rates of burnout are high. It's a very interesting question why. Some of it's due to workload, some of it may be due to fear of infection. I think a lot of it is due to the loss of collegiality. That, as Gabriel was saying, that doctors, nurses, and other healthcare providers were no longer sitting down to a meal in a hospital or interacting with each other. And even when we did, the only reason York and I could talk without masks is because we were outside in the parking lot, actually. Otherwise, even if we bumped into each other in the hospital, we'd both be talking with masks. This is a suggestion that we need to rehumanize the health system. Now, I'm a psychiatrist who works in palliative and supportive care. And one of the things I've been working toward is to see that we pay more attention to the physical, psychological well-being of our patients. I think what the pandemic revealed is that the well-being of the healthcare providers and the well-being of the patients are connected. Years ago when I was at it was actually at the Toronto General Hospital. I was in a meeting at a retreat, and they had the board there, and the board were business people, and they were saying that at that time healthcare quality seemed to be okay, but there was a lot of dissatisfaction amongst the staff at that period of time. And they were saying, from the perspective of business, this is untenable, that if you have a business in which the staff are unhappy, have low morale, the customers will eventually be affected. And of course, that's the same in healthcare. If you have burned out healthcare providers, they are not delivering high quality healthcare to their patients. They're all part of a system. And actually, there is a myth about burnout. Does anyone know the term of compassion fatigue? Have you heard that term? Has anyone heard that term? Does anyone believe that that is a cause of burnout? Is compassion fatigue? I mean, it's a common thesis, but does anybody here believe that, or how many people think that's true? Do you think that's true? Does anybody think that's not true? Were you going to say something? Well, and do you think that too much fatigue, too much compassion depletes you? Is that what you believe? So here's an alternate idea. I believe that can happen, but here's an alternate idea, actually, that burnout comes from disconnection. That even if you're working hard, even if you're dealing with seriously ill patients, if there's human connection, it isn't only in the interests of the patients, it's in the interests of the providers. Human beings are socially constructed. Our minds, our brains are socially constructed. So their own well-being depends on human connection. And if you see patients, we see patients who are in the midst of trauma. Serious illness is a traumatic experience for patients. There's many tragedies. If you see those patients daily and you are disconnected from them, it isn't only the patient that's adversely affected. It causes you to feel disconnected, alienated. We think burnout actually comes from disconnection rather than from overconnection, at least a lot of the time. So we need to think about how to change the system. Now, very few people in the mainstream of medicine say that. Very few people in the mainstream of medicine take the connection of doctors and their patients seriously. I could ask, how many people here actually have had formal training in communication as part of their medical or nursing or other training? Well, think about that. How is that possible? Think about how fundamental a skill communication is. And I hear every day, I work in a place where actually there's lots of nice people. I know the doctors are nice people and the nurses, but every day I hear what I would consider unempathic and even unprofessional kinds of communication. It's not because they're bad people. I know them. They're nice people. It's because we don't train people. And people don't think of that as part of their job. They think that diagnosis and prescribing treatment is part of their job. They don't understand that communication. Similarly, like that anecdote you told me as we were standing outside York, that fellow had not had training in how do you communicate with an upset patient. And yet think about how much a part of medicine is dealing with upset patients. Patients are in the middle of highly stressful situations. Of course they will be upset. We did a study of burnout. Actually, we partnered with the cardiac program at the University Health Network and looked at burnout using this well-being index. And as Gabriel said, that the figures are remarkably high, 70 to 80% in doctors and nurses. That may be an overestimate because I'm not sure how valid that measure is, but I wouldn't doubt that it's high. But what was the interesting thing to me that surprised? I wasn't surprised by this because it's in the literature and we all see it every day. What's surprising to me was that the burnout wasn't only in the doctors and nurses. It was even in the administrative staff. Everyone was feeling it. And everyone was feeling that it affected the quality of their care and it affected their personal life. But the fact that the administrative staff just speaks to the fact that we're all in this system together, but we don't think of it that way. We all think of us in our own individual worlds. And so I think the solution to burnout is probably not, although I'm supporting it, individual help could be very important for people who are depressed or anxious. But I think the solutions need also to involve systems rather than just trying to help each individual. So that's about what I'm talking about is the interconnected well-being of patients, families, healthcare providers, and the community. We did a piece about that, and in connection to palliative care, and I do think that the public health dimensions of an infection, I think, reminded us about that. We could no longer think of just about what we're doing, and medicine within institutions needed now to connect to public health, which tended not to occur. These have tended to be two different silos: the world of medicine and the world of public health, and the world of global health. And we were on a call yesterday dealing with this, and we had a group of people also from the world of medical anthropology, the study of societies, and they said that's a separate world, and of course it shouldn't be. If we're trying to think about how to manage a pandemic, we need to think about societies. Some people, the pandemic reminded them about this, that we're all in this together. Of course, I don't think it was as large dimension in Canada as the United States, but for other people it had the exact opposite effect. They responded to these societal expectations with the assertion of individual rights. We had a freedom convoy in Canada. It was about, you actually can't tell us what to do, that we have to have vaccines and mandates. And of course, we saw in America and many other parts of the world this rejection of the idea that we're interconnected. Really, it's about individual rights. So one aspect of human connection is, as I've been saying, is medical communication. This came from a qualitative study we did in patients with metastatic cancer. This patient said, I was completely shattered when she received the news of her diagnosis. Like everything fell beneath me. I'll never forget the doctor's words when he said it. I went to see him as one person and I left completely devastated. This is not unique. That patient describes it very vividly. Doctors, as a rule, don't understand this. Doctors don't understand the impact their words have on patients, and even if they do, time is not taken to empathically engage with patients. Maybe I'll ask you, why do you think people don't do that? Or if you agree with that, why do you think people don't take the time in clinics? What do you think the reasons are? I know clinics are busy, which is one time. Are there other reasons, though, why people don't do it? Anybody have a thought about that? Yes. They don't feel competent. I think that's one reason. We don't know what to do. And that speaks to the idea of training. You know, if you're a nurse, let's say, you've had training in wound care, but you might not have had training in that. And the same with doctors. We'd have training in all kinds of aspects of diagnosis. Any other reasons? Yes. Yes. I think that's very true, life experience, and I think that's particularly true of the younger physicians. You know, as you grow older, you have to face one kind of trauma or another. You lose grandparents, or you lose parents. You may have illness in yourself or your family. So there may be a lack of life experience, and therefore a lack of empathy. Any other? Yeah, York. Yeah. In a positive way, you mean? Yeah, 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 yeah. I mean, one of the reasons I went in internal medicine actually originally was because as a medical student, the people in those days there was a lot of wise old senior general internists, and those were the people who had that kind of empathy and wisdom. The life had, you have a few knocks if you live long enough, and those were the people I also found had empathy. Yes, Gabriel. Yeah, 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 yeah. I agree. I would say there's two other reasons. One is you're going to have to feel something if you do that. And some people are afraid of feeling bad. Empathy involves feeling something with the patient. So you have to be prepared to feel something. There's also a myth. The myth is that if I enter that, if I ask more about that, I'm going to have to take all day. That I don't have the time to do it. I think that's wrong. It's a myth, actually. Patients understand that you don't have all day, and even taking a brief time to empathize with, validate the patient's experience has a calming effect and may actually allow the interview to end sooner than later, but it doesn't take an hour to do that. It might take 5 or 10 minutes to do that. And it might be the most important thing you do for the patient. I hear every day of the week the patient's complaining about that. The doctor seems competent, but he knows nothing about me as a person, doesn't seem to care what I'm going through. There are very good guidelines. This is in cancer. ASCO, the American Society of Clinical Oncology, has published, I think, very thoughtful guidelines about communication in oncology, but they apply across medicine. However, as I said, nowhere in postgraduate training programs is there systematic training in communication skills. This is a huge blind spot in medicine, and it relates, I think it was Gabriel, someone said, we've gotten distracted by technology and the biological aspects. This is a bias that runs through medicine. And it can be quite tragic. Even now, I talked about what happened in that study in the late 90s, but this happens in the last weeks of life, that significant proportion of patients are getting chemotherapy in the last 2 weeks of life, are ending up in ICUs, in hospitals. Why do you think this is happening? Why are people in the last 2 weeks of life or month of life getting chemotherapy? Chemotherapy, as you may know, is futile and toxic, likely to make things worse. In fact, there was a study that came out in the late 90s, people with non-small cell lung cancer. They compared people with early palliative care to usual care with non-small cell lung cancer. And the intent of the trial was to show better quality of life with early palliative care. But the early palliative care group lived longer, which is kind of interesting because that's not the intent of early palliative care. But they got less chemotherapy. Chemotherapy is not good for you. So why is that happening? Why would people do that? Anybody have an idea? Yes. Yeah, so there's a medical anthropologist from San Francisco who studied this in General Hospital. She described it as a train that keeps moving. Nobody actually unpacks the question. What are the goals of care? What are the values of the patient? It's just something that keeps happening, aggressive care. Any other thoughts? Yeah. 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 So neither the doctor nor the patient want to lose hope. Yeah. It seems easier, right? But of course, what I say is that for cancer, chemotherapy, hope is actually an off-label indication for chemotherapy. It's not a good treatment for chemotherapy. It's toxic. It makes things worse, but it seems easier. And I'd like to come back to that point. Yes?
Oh, I was just going to say that sometimes when patients wind up in the hospital, you're the team taking care of them, but you have no history with them at all. The people who know them the best, their outpatient physicians, aren't involved. And so you don't have that, you don't know what they would want. And,
that's true.
And as the frontline team, you're so busy.
Yeah.
It's actually much easier to just do everything than to do less. And so that's...
But think how costly it is. It's financially costly. It's futile. It's toxic, actually. I think one of the reasons in addition is, and this maybe fits with what you were saying, is that sometimes people find it easier to prescribe than to have a conversation. I saw a patient who had advanced cancer. I had talked to the patient about going to the hospice. The oncologist came by and prescribed chemotherapy, and I was standing in the hallway, and she came out and apologized to me. So why are you apologizing to me? It's because she knew she shouldn't have done it, but it was easier than having a difficult conversation. Yes.
Pressure from the family, who may be ill-informed or have unrealistic hopes of improvement. And the other situation is when there's distant relatives that haven't been involved that show up at the end of life, and I think they're working through their guilt.
So
pressuring you to do everything.
These are all the reasons, and all of these things take time and conversations. right? So people need to spend some time in a conversation. Otherwise, it's easier to prescribe. So this is the tilt in medicine. So what I'm talking about is the tilt towards the biological and the technological, rather than to the human and the psychological and the social. And the question is, can we shift that tilt? And can we also treat mental health as part of health? Because part of this tilt is to think that medicine is about biologicalness and to not think about psychological problems as real. And as Gabriel's right, we don't measure them in the same way with a scan or with a blood test. We know that the psychological burden is great. This is research in cancer. Study in the New England Journal showed that in the first week after diagnosis of cancer, the rate of suicide goes up 12-fold, and the cardiac mortality goes up 4-fold. And this continues even a year later. This is because of overwhelming stress, right? People have acute stress disorders, especially with acute onset. We looked at this in acute leukemia. And at the time of diagnosis, a third of these people have symptoms of PTSD. We've now created, within a quarter of these patients have, patients with metastatic cancer have clinically significant symptoms of depression and demoralization. And these grow with the progression of disease. This is a trial. Psychological interventions actually are helpful. It's a randomized controlled trial of an intervention we developed called Managing Cancer and Living Meaningfully, randomized over 300 patients. And the quantitative outcomes were positive, but the qualitative outcomes, I think, were even more powerful. This has been the only opportunity for us to be looked at as people by the medical system. I think that is really important because you're more than the sum of your parts, which tells us, I think, about what the intervention did, but it also tells us about what's missing in medical care. And so why is this? I would say all over the world, psychosocial care is under-resourced, it's unsystematic, it's reactive rather than proactive. It's the least expensive part of medical care, and it's the least well-resourced. So this is the bias that exists, and it's a blind spot. It's taken to be, I have all the time, people say we can't provide more psychological care because we can't afford it. But of course, it's a tiny percentage of the expense of other care. So it's not about affordability. It's about whether it's regarded as having value. And a very interesting commission on culture and health in the Lancet. And these are their words. The system of values in medicine favors interventions that involve biology and technology over those that involve empathy. And every time I talk to a medical audience, I always worry, will they take seriously what I'm saying, as seriously as they would take if I was talking about something biological. So I'll just say we created this program. This is, I could say, a consequence of the pandemic, the Cancer Experience Program. You know, I was involved in leading a program of supportive care, psychosocial, palliative care, and cancer rehabilitation. But we've now tried to look cancer-wide, the cancer program-wide, is how can we improve the experience of the patient. And we identified these 5 targets, which we gave the acronym of Sunday: supportive communication, navigation, diversity and equity, the ambience, engagement. And actually, there was in Canada something called Heritage Minutes. I don't know if anybody in Canada remembers that. In the cinema, they showed a couple of minutes of Canadian history. Do you remember that? I think it was quite powerful because there were only a few minutes, and it was probably a decade ago that you saw it. We're now creating this about moments in communication. We've got the same film producer and director who's creating these cinematic vignettes to highlight challenges in communication and solutions to draw attention to this, which we hope will have an influence. We're creating a navigation system, which we're calling Cancer Space, an online navigation system to connect people to digital information, to lay volunteers, lay navigators, e-coaches, electronic, non-synchronous people who will help guide the patient through the system, and then to all kinds of psychosocial, medical, nursing supports. And we've gotten philanthropic funding also to create this. We're trying to pay attention to equity, diversity, and inclusion in all aspects, both in the creation of this kind of navigation system, but even as you walk into the cancer center, does it feel that all races, all people are represented in the healthcare providers and even in the ambience of the cancer center? So we're trying to pay attention to the physical space. We've partnered with the Toronto Symphony and the Art Gallery of Ontario to bring art and music into the Cancer Centre. And the reception, I think, has been remarkable. It has a very powerful effect when you have music in a healthcare setting. And we've created what we're calling Symphonies for the Soul. We had these weekly concerts, but this is not a concert. This is an individual musician sitting outside the radiation therapy center, sitting outside the dialysis unit, or in our case, the chemotherapy unit. This is something that's been meaningful to the musicians and has made a very difference to the experience of the patients. And to try to think about ways of engaging staff to address burnout and ways of engaging patients and families. How can we have everyone feel involved, that we're partners in healthcare? Because I think burnout has a lot to do with disengagement. So I'm going to stop and say that, just tell you that we've taken this on as a larger project, which we've called Optimizing the Balance Between Biomedicine and the Soul of Medicine. And we think the soul of medicine, which is, I think, what I've been talking about, is what's been lost in the last 50 or 75 years. And actually in the field, I think it's most evident. I think this is prevalent in all of medicine, but we think there needs to be most attention to this in people with more advanced disease. These are the people for whom these things become even more important. And actually, we've now been invited by Lancet Oncology to undertake a Lancet Commission on this so-called humanitarian crisis of cancer, which I think exists in all of medicine, and I think the pandemic has drawn our attention to it. So on that note, I'd like to stop, and I'm very interested in people's comments and discussion.